Welcome to our second video on chest trauma. Let's begin. In this lecture, we'll discuss pulmonary contusion and diaphragmatic rupture. For each of these conditions, we'll cover general characteristics, etiologies, clinical features, diagnosis, and management. Let's begin. First, let's discuss the pathophysiology behind pulmonary contusion. To start with, a pulmonary contusion is an injury to the lung parenchyma, most commonly from blunt trauma, leading to lung consolidation and collapse, secondary to edema and blood accumulation in the alveoli. Let's take a minute and understand this process. Pulmonary contusion injures the vessels and alveolar capillary membrane. These injuries to the vessel and membranes lead to fluid buildup in the interstitium, causing impaired gas exchange and eventually hypoxia and respiratory failure. Inflammatory cells in the leaked fluid and blood invade the lung parenchyma, leading to decreased surfactant production and inflammation, further increasing the chance of lung consolidation and collapse. Another important concept is hypoxic pulmonary vasoconstriction. Let's review this process. When a certain amount of blood is not properly oxygenated in the lungs due to various respiratory medical conditions, hypoxia occurs. In response to hypoxia, intrapulmonary vessels constrict to direct the blood flow to better oxygenated lung areas and prevent ventilation-perfusion mismatch. A VQ mismatch occurs when blood is flowing through vessels without oxygenation or when the lung receives oxygen without proper blood flow. To sum up, ventilation-perfusion mismatch, VQ mismatch, occurs in patients with pulmonary contusion due to less hemoglobin being saturated with oxygen over the damaged lung tissue, resulting in further respiratory compromise and hypoxic pulmonary vasoconstriction. Here you see a chest x-ray of pulmonary contusion with consolidated areas in white on the right side. Note that these consolidated areas in white are the result of damaged capillaries leaking blood or accumulation of other fluids in the interstitium due to bruising of the lung. Some of the high-yield etiologies of pulmonary contusion tested on boards are blunt trauma due to rapid deceleration, sports injuries or falls, penetrating trauma, localized lesions such as fractured ribs, and lung tissue shearing. Let's move on to a discussion about the clinical features now. Classically, patients with pulmonary contusion report dyspnea, painful breathing, hemoptysis, and wheezing. Physical exam often reveals hypotension, tachycardia, tachypnea, and decreased breath sounds over the affected area due to possible atelectasis, or collapse from blood accumulation, inflammation, and tissue edema. Note that the presence of symptoms depend on severity of the condition. Sometimes patients are asymptomatic initially and can develop signs slowly. Other times, they can deteriorate rapidly. Let's talk about the diagnostic approach. Besides clinical presentation, we use various imaging modalities. Most commonly used is a chest x-ray, which depicts pulmonary contusion with consolidation, infiltrates, and hemorrhage. These all may appear as irregular opacifications on the chest x-ray. Note that an initial chest x-ray is not very sensitive, as pulmonary changes may take 24 to 48 hours to be visible on imaging. CT scan can be used to better define the injury and has better resolution. However, this will rarely change the management. How could you use a chest x-ray to differentiate between a pulmonary contusion and pneumothorax? As we just covered, in the setting of a pulmonary contusion, a chest x-ray would show areas of consolidation and opacification, which appear white on the x-ray. This is because the pulmonary vessels are damaged and allowing blood and fluid to accumulate in the interstitium. In the setting of a pneumothorax, the affected lung would be collapsed due to equilibrium of the pleural pressure, which is normally negative with the atmospheric pressure. On chest x-ray, we would see the visceral pleura pushed in close to the mediastinum as evidence that the lung is collapsed. We would also lose the normal lung markings peripheral to the collapsed lung. Finally, let's discuss management. The primary goal in pulmonary contusions is to provide supportive management. More specifically, patients are initially monitored for their respiratory function, and if needed, oxygen therapy is provided. Also, CPAP or BiPAP may be used to provide positive pressure to open up the lungs and improve blood oxygenation. Note that when patients have higher significant hypoxia, they may need intubation and mechanical ventilation to reopen the collapsed airways, increase oxygenation, and treat pulmonary edema. Furthermore, for improvement of breathing and good clearance of secretions, it is important to provide pain control so patients are able to cough and take deep breaths without pain. Another useful management option is chest physiotherapy, chest percussion, and optimal positioning in which case unaffected lung is placed in a dependent position. In a dependent position, the unaffected lung is placed down, directing the majority of blood flow towards the healthy lung, resulting in appropriate oxygenation. Now that we've reviewed pulmonary contusion, let's move on to discuss diaphragmatic rupture. Usually, diaphragmatic rupture occurs due to blunt or penetrating trauma. Let's take a minute and understand the various mechanisms that lead to diaphragmatic rupture. Pressure can be applied to the diaphragm directly via either anterior compression or lateral compression. The compression leads to an increased pressure gradient between the peritoneal and pleural cavities. Because the posterolateral diaphragm is the weakest point, this increase in pressure can cause that area to rupture. Note that most diaphragmatic injuries occur in the left side, as the right side is protected by the liver. Next, let's discuss the commonly tested risk factors. As we've already mentioned, diaphragmatic rupture results from either penetrating trauma, such as a gunshot or stab wound, or blunt trauma, such as a motorcycle or car accident. Now let's discuss the clinical features. Classically, patients report dyspnea, chest pain, abdominal pain, nausea, and vomiting. For your board, you're expected to know the typical physical exam findings, such as bowel sounds on cardiac or lung auscultation, decreased breath sounds, and a scaphoid abdomen. Note that the above-mentioned symptoms and clinical findings are the results of the internal evisceration of abdominal organs in the chest through the diaphragmatic tear. This leads to lung compression, respiratory compromise, and possible abdominal obstruction. Now let's move on to a discussion about the diagnostic approach. After physical examination and any stabilization of the patient, a fast exam and X-ray are indicated for all patients. Typically, the fast exam reveals large tears through the diaphragm along with eviscerated organs in the chest. Chest X-ray is not highly sensitive or specific, but remains still one of the most important imaging studies in patients with diaphragmatic rupture. Usually, chest X-ray may depict an elevated diaphragm, a gastric or colonic bubble in the left chest, a coiled nasogastric tube if one has been placed, possible rib fractures, and pneumoperitoneum. If chest X-ray shows any of these findings, the next best step is surgical intervention. However, if the chest X-ray is non-diagnostic or abnormal, a CT scan can be used for further workup. Though a CT scan cannot completely visualize the diaphragm, it is still more accurate than radiography. In this chest X-ray, you can see the marked cranial displacement of the diaphragm as well as the stomach. This finding is most commonly found in a diaphragmatic rupture that leads to the displacement of the abdominal organs. Finally, let's talk about treatment. The initial goal for the management is to resuscitate the patient according to the ABCDE's protocol. If patients are hypotensive, give IV fluids, along with IV pain medication for pain control. When diaphragmatic rupture is suspected, an NG tube is placed for abdominal decompression and imaging is obtained. Once confirmed by imaging, surgical repair becomes necessary. Let's take a minute and understand the indications for certain surgical procedures. If a patient has an acute diaphragmatic injury, exploratory laparoscopy or laparotomy is recommended to reduce the hernia, evacuate blood, and perform debridement along with the repair. A patient presents to the emergency department following a motorcycle accident. On physical exam, bowel sounds are noted when auscultating the heart. What additional findings would be expected on continued physical examination of this patient? Based on the recent motorcycle accident paired with the finding of bowel sounds in the chest region, you should be highly suspicious of a ruptured diaphragm. Because the diaphragm is ruptured and no longer acting as a barrier, the abdominal viscera are displaced superiorly into the thoracic cavity. This leads to findings of decreased breath sounds since the lungs have less room in the thorax, and a scaphoid abdomen because some of the abdominal organs are now residing in the thorax, leaving residual space in the abdomen. Let's try a question. A 28-year-old man is brought to the emergency department due to severe chest and abdominal pain after being involved in a motorcycle accident 1 hour ago. His past medical history is non-contributory. His vital signs include a temperature of 37 degrees Celsius, a blood pressure of 100/70, heart rate of 92, and a respiratory rate of 22. Physical exam reveals a scaphoid abdomen along with bowel sounds on lung auscultation. ECG is unremarkable, and cardiac troponin 1 is normal. Intravenous normal saline is initiated, and a fast exam has been performed. Which of the following is the best next step in the diagnosis of this patient? A. Chest X-ray. B. Chest CT scan. C. PET scan. D. PET CT scan. This young man presents with severe chest and abdominal pain after being involved in a motorcycle accident 1 hour ago. His vital signs are significant for tachypnea with the respiratory rate of 22 breaths per minute. Physical exam reveals a scaphoid abdomen along with bowel sounds on lung auscultation. These findings are classic for a diaphragmatic rupture. Intravenous normal saline is initiated to support the patient's hemodynamic status, and fast exam has been performed. The best next step in the diagnosis of the diaphragmatic rupture is a chest x-ray. Chest x-ray typically shows an elevated diaphragm and a gastric or colonic bubble in the left hemithorax. It may also show pneumoperitoneum or rib fracture. Therefore, the correct answer is option A. Here's a slide reminding us of the diagnosis of diaphragmatic rupture. Pause the video and take a moment to review this slide once again. Let's discuss why other options are incorrect. Option B is incorrect because the chest CT scan is only performed in a patient with suspected diaphragmatic rupture if the chest x-ray is non-diagnostic or abnormal. Options C and D are incorrect because a PET scan and PET CT scan are not indicated in this patient with diaphragmatic rupture. And that concludes our lecture on pulmonary contusion and diaphragmatic rupture.